Topic number 15, Basics of the Transplantology, lecturer Shevchenko Alexander, Baltic Federal University Medical Institute, Kaliningrad 2020. So, transplantology. It is the field of medicine which studies transplantation of organs and tissues. We must meet some definitions which help you in further discussion of transplantology. Xenotransplantation. It's transplantation of organs and tissues from an animal or another biological species. Allotransplantations, allografts, a transplant in which the donor of the transplant is a same species, in case of medicine, genetically and immunologically different human body. Allografts can either be formed from a living or cadaveric source. Allotransplantation or autografts, the recipient of the transplant is a donor for himself. As we see on this picture, we see skin graft. So from one part of the human body, of the patient's body, we take skin to set it where injury was. So we close the defect of the skin. Transplant immunobiology. Early experience in transplantology was devastating. Most of the trial was unsuccessful. Rejection was a common complication because scientists of the early transplantology didn't understand the mechanism of histocompatibility. Earliest experience in kidney transplant made by Voronoi Yuri Yuryevich in 1933 in Kharkiv, Soviet Union. But the outcome was disappointing because, as I say earlier, surgeons didn't know about histocompatibility enough material, so rejection was very common for that time. Almost always, and he is a pioneer of human organ transplant, but all results was disappointing. History of the first long-term successful organ transplantation. Kidney 1954, liver 1963, lung 1963, pancreas 1966, heart 1967, small intestine 1967, heart-lung complex 1981, multivisceral 1989. As you see on the picture, it is a dog with two heads. It was experiment of such scientist Demikhov in Soviet Union. In 1957 he transplanted head of the dog because it was many experiments of artificial organ placed in the body of the animal, and he is the first scientist who placed artificial heart into the animal, into the dog in 1937, and the dog lived for 2 hours more. In case of these dogs, he tried to transplant some organs from one species, from one dog to another dog, but this dog was in the car accident, and he tried to save her life, and he transplanted head of the dog to another dog, and this dog lived for 10 days in the basement. As you see, most of the transplant was made in the United States because it's too high in costs. Only heart transplant was firstly made in Cape Town, that is South Africa, by Christian Bernard. On this picture we see transplantation of the heart in Cape Town in 1967. On the picture on the right, it's a Life cover magazine. On the right from patient, it's Carl Bernard by himself with successful transplanted heart. We see that patient is smiled here. Transplants between genetically non-identical persons lead to recognition and rejection of the organ by the recipient's immune system, if no intervention is undertaken. The main antigens responsible for this process are part of the major histocompatibility complex. In humans, these antigens make up the human leukocyte antigen system. Two major classes of HLA antigen are recognized. Class 1 antigens, HLA-A, HLA-B, and HLA-C, are expressed by all nucleated cells. Class 2 antigens, HLA-DR, HLA-DP, and HLA-DQ, are expressed by antigen-presenting cells such as B lymphocytes, dendritic cells, macrophages, and other phagocytic cells. We have three different types of rejection. It's fulminant rejection, acute rejection, and chronic rejection. Fulminant rejection, hyperacute rejection, a very rapid type of rejection, results in irreversible damage and graft loss within minutes to hours after organ reperfusion. It is triggered by performed antibodies against the donor HLA or AB0 blood group antigens. These antibodies activate a series of events that result in diffuse intravascular coagulation, causing ischemic necrosis of the graft. Fortunately, pre-transplant blood groups typing and cross-matching, in which the donor cells are mixed with their recipient's serum, and then destruction of the cell is observed, have virtually eliminated the incidence of hyperacute rejection. On this picture, we see mechanism of acute rejection of a kidney graft through the direct pathway of our recognition. So we have kidney graft with dendritic cells. Dendritic cells migrate to the spleen, where they activate effector T cells. Effector T cells migrate to the graft via blood. Graft destroyed by effector T cells. Acute rejection takes days to develop. The rejected graft is swollen and has deep red areas of hemorrhage and gray areas of necrotic tissue. Acute rejection. The most common type of rejection usually occurs within a few days or weeks post-transplant. According to the mechanism involved, it is further divided into cellular T-cell mediated rejection, humoral antibody-mediated rejection, or a combination of both. The diagnosis is based on the results of biopsies of the transplanted organs, special immunologic stains, and laboratory tests, such as elevated creatinine levels in kidney transplant recipients, elevated liver function values in liver transplant recipients, and elevated levels of glucose, amylase, and lipase in pancreas transplant recipients. Chronic rejection. Chronic rejection is a slow type of rejection. It can manifest within the first year post-transplant, but most often progress gradually over several years. The mechanism is not well understood, but the pathologic changes eventually lead to fibrosis and loss of graft function. With advances in immunosuppression, this relatively rare form of rejection is becoming more common. Graft versus host disease. I know, in case of the surgery, it doesn't mean anything because we talk about bone marrow transplant, but if we talk in general about transplantology, It's the part of the transplantology. So, graft versus host disease is a syndrome characterized by inflammation in different organs with the specificity of epithelial cell apoptosis and creep dropout. Graft versus host disease is commonly associated with stem cells transplants such as those that occur with bone marrow transplants. Graft versus host disease also applies to other forms of transplanted tissue such as solid organ transplants. White blood cells of the donor's immune system, which remain within the donated tissue, recognize the recipient as foreign. The white blood cells represent within the transplanted tissue then attack the recipient's body cells, which leads to graft versus host disease. This should not be confused with a transplant rejection, which occurs when the immune system of the transplant recipient rejects the transplanted tissue. A graft versus host disease occurs when the donor's immune system, white blood cells, reject the recipient. The underlying principle of immunity is the same, but the details and course may differ. Graft versus host disease can also occur after a blood transfusion, if the blood products used have not been irradiated or treated with an approved pathogen reduction system. An immunosuppressive protocol includes first, induction with anti-T lymphocyte depleting or non-depleting antibodies, and second, maintenance with calcineurin inhibitors, antiproliferative agents, and corticosteroids. So, induction. I drew you an arrow with head up because we highly suppress the immune system. So, induction includes the use of depleting polyclonal antibodies or non-depleting antibodies within the first month post-transplant. Depleting antibodies. Thymoglobulin and AdGam contains antibodies to T cells and B lymphocytes, B cells, integrins and other adhesion molecules, thereby resulting in rapid depletion of peripheral lymphocytes. Non-depleting antibodies. Basiliximab, Simulect, and alemtuzumab, Campath, anti-CD25 monoclonal antibodies. The alpha subunit of the interleukin-2 receptor, also known as Tecor CD25, is found exclusively on activated T cells. Blockade of this component by monoclonal antibodies selectively prevents yield to reduced T cell activation. Humoral rejection. Another part of the drugs directed to prevent humoral rejection through their mechanism of action. Rituximab, bortezomib, eculizumab. Here we see immunosuppressive drugs by grouping. Those of you who need to write down these groups, please make pause and write down this. And we go next slide. Next stage of immunosuppression is maintenance. So I draw the line horizontal, so we go on the plateau. Corticosteroids have had a role in immunosuppression since the beginning of the field of transplantation. Despite numerous attempts to limit or discontinue their use, they remain an integral component of most immunosuppressive protocols, for both induction and maintenance. Moreover, they are often the first-line agents in the treatment of acute rejection. Steroids bind to glucocorticoid responsive elements in DNA that prevent the transcription of cytokine genes and cytokine receptors. In addition, steroids have an impact on lymphocyte depletion, on increased cell-mediated immunity, and on T-cell activation of many phases of rejection. Here we see classification of corticosteroid. Also, those of you who need to write down these numbers and these names of the corticosteroids, please make the pause and write down. And we go next slide. Here you see a table which describes in which year these corticosteroids was synthesized. And if you compare it with the first years of the transplant, you must see that transplantology was a real field of the medicine after describing all these types of the corticosteroids, because without corticosteroids we talk about acute rejection. Next type of dysfunction is graft dysfunction. The process of brain death is associated with a cytokine storm. In donors, warm ischemia occurs. These processes, as well as cold storage and then reperfusion in the recipient, result in ischemia reperfusion that can impact on graft function. This is sometimes referred to as harvest injury. Initial poor function or delayed graft function may necessitate supportive measures, such as dialysis in the case of kidney transplantation. Complete early failure of the graft is referred to as primary non-function, and urgent retransplantation of non-renal grafts is required to prevent death. Chronic transplant dysfunction, which can lead to late graft loss, can occur through incompletely understood complex immunological and non-immunological mechanisms. The pathology of chronic transplant dysfunction varies between different organs and includes intestinal fibrosis, interstitial fibrosis, and tubular atrophy of the kidney, graft fibrosis, and ductopenia in the liver, bronchiolitis obliterans in the lung, and arteriosclerosis in the heart. Infections and malignancies. Advances in immunosuppression have led to improved graft survival rates. However, the growing population of immunosuppressed patients in turn has led to an increased incidence of opportunistic infections and malignancies. Such post-transplant complications have become important barriers to long-term disease-free survival. Infections. Transplant recipients are predisposed to a variety of infections. Immunosuppression is the obvious reason. Moreover, such patients have already endured end-stage organ disease pre-transplant, and then the stress of an invasive transplant operation. Post-transplant, they continue to have significant comorbid conditions. Early infections. Infections occurring within 1 month post-transplant can be due to a wide spectrum of pathogens, bacterial, viral, and fungal. In the immediate postoperative period, recipients are significantly compromised from the stress of the operation, from induction immunosuppression, and often from initial impaired graft dysfunction. Infections during this period can be devastating. Treatment should be aggressive, often including empiric antibiotics and antifungal medication, even before cultural results are available. Recipients of organs from infected donors should be treated per the results of donor culture specification and the antibiotic sensitivity profile. Late infection. Primarily due to chronic immunosuppression, specifically the depression of cell-mediated injury, cell-mediated immunity, that renders recipients susceptible to viruses, fungi, and parasites. The herpes simplex virus, cytomegalovirus, and Epstein-Barr virus are most common. Opportunistic infection with Aspergillus, Cryptococcus, Mucor, and Rhizostopisia species are rare but can cause serious infections. Patients with invasive Candida or Aspergillus infections have a 20% mortality rate. Prophylaxis with fluconazole has been shown to reduce invasive fungal infection in liver recipients. Malignancies. Chronic immunosuppression increases the risk of developing certain types of malignancies. The most extensive data from a cohort study involving more than 175,000 solid organ transplant recipients showed that 10,656 of them developed malignancies. The standardized incidence ratio was 2.1 as compared with general population. Recipients had at least a five-fold increase as compared with the general population. This type of malignancies, Kaposi's sarcoma, non-melanoma skin cancer, non-Hodgkin's lymphoma, and cancer of the liver, anus, vulva, and lip. In addition, recipients had a statistically significant increase as compared with the general population in melanoma, Hodgkin's lymphoma, and cancer of the lung, kidney, colon, rectum, and pancreas. Legal ground. In the Russian Federation, we have a law about transplantation of organs. I placed here in Russian if you want to find it and read it. And I take a few words from this law. Organ or tissue transplantation from a living donor or cadaver can only be used if other medical means cannot guarantee the preservation of the patient recipient's life or the restoration of his or her health. The removal of organs and tissues from a living donor is allowed only if their health is not significantly harmed by the conclusion of a consultation of medical specialists. And here I take the legal ground which takes place in the World Health Organization, its recommendation to all nations around the world. And this is the basic principles. So, first principle: cells, tissues and organs may be removed from the bodies of deceased persons for the purpose of transplantation if any consent required by law is obtained, and there is no reason to believe that the deceased person objected to such removal. Physicians determine that a potential donor has died should not be directly involved in cell, tissue or organ removal from the donor or subsequent transplantation procedures, nor should they be responsible for the care of any intended recipients of such cells, tissues and organs. Donation from deceased person should be developed to its maximum therapeutic potential, but adult living person may donate organs as permitted by domestic regulations. In general, living donors should be genetically, legally and emotionally related to their recipients. Live donations are acceptable when the donor informed and voluntary consent is obtained, when professional care of donors is ensured and follow-up is well organized, and when selection criteria for donors are scrupulously applied and monitored. Live donors should be informed of the probable risks, benefits and consequences of donation in a complete and understandable fashion. They should be legally competent and capable of weighing the information, and they should be acting willingly, free of any undue influence or coercion. No cells, tissues or organs should be removed from the body of a living minor for the purpose of transplantation other than narrow exceptions allowed under the national law. Specific measures should be in place to protect the minor, and wherever possible the minor's assent should be obtained before donation. What is applicable to minors also applies to any legally incompetent person. Cells, tissues and organs should only be donated freely, without any monetary payment or other reward of monetary value. Purchasing or offering to purchase cells, tissues and organs for transplantation or their sale by living persons or by the next of the kin for deceased persons should be banned. The prohibition on sale or purchase of cells, tissues, and organs does not preclude reimbursing reasonable and verifiable expenses incurred by the donor, including loss of income, or paying the cost of recovering, processing, preserving, and supplying human cells, tissues, or organs for transplantation. Promotion of altruistic donation of human cells, tissues, or organs by means of advertisement or public appeal may be undertaken in accordance with domestic regulation. Advertising the need for or availability of cells, tissues, or organs with a view to offering or seeking payment to individuals for their cells, tissues, or organs, or to the next kin, where the individual is deceased, should be prohibited. Brokering that involves payment to such individuals or to the third parties should also be prohibited. Physicians and other health professionals should not engage in transplantation procedures, and health insurers and other payers should not cover such procedures if the cells, tissues, or organs concerned have been obtained through exploitation or curation or payment to the donor or the next kin of a deceased donor. All healthcare facilities and professionals involved in cell, tissue, or organ procurement and transplantation procedures should be prohibited from receiving any payment that exceeds the justifiable fee for the services rendered. The allocation of organ cells and tissues should be guided by clinical criteria and ethical norms, not financial or other consideration. Allocations rules defined by appropriately constituted committees should be equitable, externally justified, and transparent. High quality, safe, and efficacious procedures are essential for donors and recipients alike. The long-term outcomes of cells, tissue, and organ donation and transplantation should be assessed for the living donors as well as the recipient in order to document benefit and harm, the level of safety, efficacy, and quality of human cells, tissues, and organs for transplantation as health products of any exceptional nature must be maintained and optimized on an ongoing basis. This requires implementation of quality systems including traceability and vigilance, with adverse events and reactions reported both nationally and for export human products. The organization and execution of donation and transplantation activities, as well as their clinical results, must be transparent and open to scrutiny while ensuring that the personal anonymity and privacy of donors and recipients are always protected. Typically, brain death is defined as the irreversible cessation of brain function, including the brainstem. The presence of medical conditions that mimic brain death, such as drug overdose, medication side effects, severe hypothermia, hypoglycemia, induced coma, and chronic vegetative state, need to be excluded. The latest evidence-based guideline on determining brain death in adults reaffirmed the validity of current clinical practice. Briefly, the clinical diagnosis of a brain death consists of four essential steps. A. Establishment of the proximate cause of the neurologic insult. B. Clinical examination to determine coma, absence of brainstem reflexes, and apnea. C. Utilization of ancillary tests such as electroencephalography, cerebral angiography, and/or nuclear scans in patients who do not meet clinical criteria and appropriate documentation. So here we saw the scheme. Donation after brain death. Brain death, transfer to operating theater, laparotomy, sternotomy cannulation, cold perfusion, and cold storage. And then reperfusion. Donation after circulatory death. Withdrawal of cardiorespiratory support, cardiac arrest, transfer to operating theatre, evaporatomie, sternotomy, cannulation, cold perfusion, and cold storage. Artificial organs. Artificial organ is a human-made organ device, the tissue that is implanted or integrated into a human interfacing with living tissue to replace a natural organ, to duplicate or augment a specific function or function so the patient may return to a normal life as soon as possible. The replaced function does not have to be related to life support, but it is often is. For example, the replacement bones and joints, such as those found in hip replacement, could also be considered as artificial organs. Implied by definition is that the device must not be continuously tethered to a stationary power supply or other stationary resources such as filters or chemical processing units, periodic rapid recharging of batteries, refilling of chemicals and or cleaning and replacing of filters would exclude the device from being called an artificial organ. Thus, a dialysis machine, while a very successful and critically important life support device that almost completely replaces the duties of the kidney, is not an artificial organ. And prosthesis. Prosthesis is an artificial device that replaces a missing body part which may be lost through trauma, disease, or a condition present at birth, congenital disorder. Prostheses are intended to restore the normal functions of the missing body part. As you see, transplantology acts in the junction of many specialties such as cardiovascular, thoracic surgery, abdominal surgery, orthopedics, trauma, oncology, immunology, and infection diseases, anesthesiology. In such conditions, multidisciplinary team is required. Thank you for your attention.